Yeah, I want to thank COLDA for giving us chance to present some data from HEPSANET. So yeah, like I've been introduced, my name is Edford from Zambia. So I'm going to look at hepatic steatosis among people with chronic Hep B infection, and we'll focus on the prevalence, predictors, and the association of liver fibrosis. So why talk about steatosis in Hep B? Very important, as you may be aware, WHO latest guidelines about treating Hep B, they are factoring a lot of things in there, and one of which are comorbid conditions. And comorbid conditions of which hepatic steatosis is one of them. And unfortunately, we have very scanty data in Africa, just like other people have presented. And more so, we don't have much data on liver steatosis in association with hepatitis B. Yeah, so this is collaborative, and if you're lucky, you can see your face there. We had, this data was extracted from 8 cohorts, and this was available in Steatosis, and this was captured on the basis of controlled attenuation parameter, which is an ultrasound-based measure to assess fat liver. Yeah, so we started with quite a big number. In terms of sample size, we thought of analyzing 13,600. And we had to exclude people who had never had any CAP. And those that had CAP, we excluded those that were out of range. For example, those whose CAP was less than 100 decibels per meter and more than 400, these were excluded. The co-infection with Hep C and D were also excluded, which now gave us about a sample size of 1,400, and then we had to stratify this with mono-infection with Hep B and co-infection with HIV. So those on the arm of mono-infection were about 1,000, and those who were co-infected were about 323. I must point out very quickly that those that were co-infected, the cohorts were from Tigerberg in South Africa and HepMec from Zambia. Virtually other cohorts only contributed those that had mono-infection. Yeah, so coming to the results. Here, what I want to emphasize is that most of our patients in both groups were in the age range between 35 and 45. And also in the mono-infected group, obesity was relatively high, about 16%. And those in the co-infected, it was about 12%. Right, so when we tried to factor in how much steatosis was there, we found that in the mono-infected group, it was about 32%, and in the co-infected group, steatosis was about 12%. Yeah, so when we tried to correlate things, we noted that obesity was strongly correlated with steatosis, both in the mono-infected group as well as in the co-infected group. So, in terms of expansion, what we need to talk about pertaining to Hep B and metabolic liver disease. So, if you note that of 345 adults with chronic Hep B alone, steatosis was found in 46%, and these were not on ART, antivirals. So, therefore, we see that according to the June guidelines, screening for steatosis in patients with Hep B in Africa may lead to treating a large number, which would be a good thing. Again, we try to associate this steatosis with liver fibrosis. We defined fibrosis using fibroscan above 7 kilopascals, which was defined as fibrosis. Again, we see here that in the monoinfected group, severe steatosis was strongly associated with fibrosis. And more so, even higher in those that had co-infection. So what are the future directions? Well, we must know that we need to do longitudinal analysis of whether steatosis causes faster liver disease progression, especially in chronic Hep B infection, with or without treatment, and this is very, very important. And we also must do analysis of whether steatosis alters markers of Hep B, such as Hep B viral load replication. And we also must, in our centers, validate alternatives to CAP. As you may know, that CAP is not readily available in most centers in Africa. And therefore, if we can validate and see if we can use things like fat liver index, B-mode ultrasound as alternatives to assessing steatosis in these centers, that would help us. And we also must have, in our Sentinel Metabolic Disease Survey, within selected HEPSANET sites to screen for metabolic syndrome and its risk factors, such as diet, physical activity, and so on. So these are important things that we must factor in. And lifestyle intervention are needed, especially in our cohorts in Africa. Right, so I want to thank HEPSANET Group and also our funders like JSM and INH. Thank you very much.